and then I want to see how we go from there. So the implementation of vaccines and their distribution has been complicated by a variety of factors. We've all heard about the challenges involved in the cold storage requirement, the special training that is required for those who are going to be administering it, which puts additional burdens on hospital and facilities. Heard all sorts of challenges about institutions and hospitals not hearing about how much vaccine they're going to receive, not always knowing exactly when. The disconnect between federal, state, and local officials. Some of the results have been kind of chaotic. In one Kentucky community, doses were almost wasted when a nursing home ordered more than they needed, and pharmacists who were administering it had to scramble to keep them from being disposed of by finding literally almost people off the street. In Palo Alto, faulty algorithms created a situation where frontline hospital residents were precluded from being vaccinated, and the headaches that ensued from there. In Wisconsin, 500 doses were deliberately wasted by a hospital employee who has since been arrested, but there's not been much explanation as what motivated him. We've seen Florida with lines that stretch quite into the distance. We've heard examples of people who have appointments who are told not to come because there is no vaccine. And then that brings me to my story. I don't really fall into one of those A, B, early categories. And I sort of contented myself with the fact that I was likely to get my vaccination probably sometime during the summer months. I figured that was a reasonable time frame for me to expect. On Thursday, Jody, however, being in category 1B, was scheduled to receive her vaccination this coming Monday. And so that was sort of a positive note in our household. On Thursday evening, just after the program on Jews and racism had ended, Jody's phone dings, meaning a text has arrived, and Jody weighs carefully the question of whether she wants to actually answer the phone. Because it's now almost 9:10, 9:15, and it's like the day is, right? But it is a text with the following information, and I paraphrase, all right? A parent in the nursery school who is a nurse, who was working at the TU as the part of the team that was distributing vaccinations today, had sent a message to our nursery school director, who then forwarded it along saying, if anybody can get here in like the next 10 minutes, we have some doses that are available. Okay, this was, okay, so Jody's telling me from the other room that the email arrived, the text arrived at 9:04. At about 9:05 and a half, we were out the door. And in the intervening time came a message, a follow-up that says, bring Rabbi.
They needed you to bless it.
It's not, it would not be the weirdest thing I've ever blessed. Okay, so we arrived downtown. Short of having Scotty beam us, I don't know that we could have arrived all that much faster. God bless my wife who was driving, and I'm trying to text responses to these people as my thumbs are bouncing into the back seat. But we arrive, we park, we run in. the guy starts to ask us some questions, and one of them is, did someone call you? We say, yes. And they say, okay, come here. And they usher us in and plop, sit, take information, blah, blah, blah. And we got the last 2 vaccines of the night.
Wow.
We were numbers 799 and 800. So because this happened very, very quickly, it probably spared me some of the ethical conundrums that I was worried about. Welcome, Assemblywoman Fahy. Thank you so much for joining us. I warn you that you're muted.
Yeah, good morning. I'm sorry. It's been a very long morning and I'm just juggling a number of things. Sorry about
right,
this. Sorry
and I
for my
recognize
delay.
that you.
And it always takes a little longer to boot up. I was on my phone and always takes a little longer to boot up than I anticipate. So my apologies, everybody. Good morning.
Morning.
We are thrilled that you can join us. And I forewent introductions because, as I said last week, if I did those, we'd have no time for a program. So for those of you who heard a little bit about Dr. Zaikon last week, ditto. If you want to know about Assemblywoman Fahy, go to her webpage. Otherwise, I'm just going to finish this little snippet of narrative and then throw the question, which is, so as I'm sitting there and chatting with the staff, I'm going, why is this? All right. And basically what I was told was that this is sort of a common occurrence in their experience, where they have, at the end of the day, which was supposed to end about an hour and a half earlier than it did, they have vaccines and they are not leaving them on the table. Right. So kol hakavod, full measure of props and credit to these people who are doing very diligent work over the course of a very long day and are not going to waste a drop of this vaccine. But the flip side is, it means that somehow or other there's a problem in the system, which is sort of the obverse of the one that Rachel had mentioned earlier about people being told, we don't have any more, even though you've got appointments, don't come.
Yes.
So I'm gonna, especially since I know that you are sort of tight on time this morning, Assemblywoman, I'm gonna throw the question to you first. How do we begin to fix the system so that people are not turned away, so that the people who are administering it aren't suddenly scrambling to find people to administer doses to? One of the things that the person I was talking to told me is that a few days ago, they were in a similar situation and they ended up vaccinating a whole group of people from the mission down the street. And part of me is going like, I'm thrilled that those people got it. On the other hand, and part two of the conversation could be, how do we prioritize who should be getting it? But part of me is going like, there's got to be a better way to get this done. So how do we solve this in 25 words or less?
That's a lot. That's a tall order. I have to say, I am so frustrated. I actually reached out to a colleague or two to see if we should be holding a press event tomorrow. So this is yesterday and the day before. So much to unpack here. Let me start by saying I've done a lot of interference throughout COVID for St. Peter's and Albany Med, especially St. Peter's throughout COVID, right? Because as you know, they were very much on the front lines. They even, to their credit, we had helicopters landing with people coming in from New York City. So, there is no doubt that healthcare workers deserve so much of the hero status that they have received, especially in the last 10 months. So fast forward now to the vaccine. I could speculate in a few ways on what's going on here, but let me first say what I understand is happening. So we were only given a limited dose, right? And then last week that the 300,000 or 300 something thousand was cut to 250,000 for the entire state. Unfortunately, though, the governor first issued the rank order, the 1A, 1B, and more of prioritizing. And even in 1A, my understanding is, and I'm pretty sure I read it this way, even with 1A, you had a few million people that were eligible under 1A. But then the CDC came out and said, well, you can also include 65-year-olds. So the governor turned around the next day when we were barely getting doses to even begin the 1A population, which does, by the way, includes the healthcare workers and a host of others, and automatically adopted the CDC guidelines. Now, I'm frustrated because, while I have too, repeatedly gone online and read the CDC guidelines on various issues over the last 10 months, 8 months, the governor has not always adopted the CDC guidelines. And when we still hadn't finished 1A, why we decided to open it up to 65-year-olds, nothing against 65-year-olds, I'm close enough. But when we have hospital workers who were on the front line that are still not vaccinated. So I lay that out to say I'm incredibly frustrated. St. Peter's, which is the second largest health provider in this 6-county or more region, is now entering their third week with zero vaccinations. And Albany Med, by the way, I understand has 0 this week as well. I'm waiting to get that confirmed. Has 0 coming into this week. So I think a little bit of what happened here is, one, the governor got I'm not trying to speak for the governor, and I'm not here to bash the governor, quite frankly. I'm just here to raise the questions. He's done a lot of good things throughout this COVID. He's, certainly put us at the forefronts, but as there's also a lot of questions about, they'll be writing textbooks about this for the next 10 years, right? About what could have, should have, would have been done. But I'm still baffled as to why we would automatically overnight adopt the CDC guidelines. And the pool now, the eligible pool in New York State is 7 million people. We only have 19 million people, and that's including children, right? Whereas, we know adults have been a priority under the vaccine for all the obvious reasons. So the pool now is 7 million people. And with 65-year-olds, often they are more technologically savvy to get in on these websites or spend the time refreshing their screens for 12 hours to get a date, whereas somebody 75 to 95 may not be as savvy. So we have nothing but frustration, and we still have countless healthcare workers in our hospitals who have not even been vaccinated. So I say that to say, I think what happened here, and I'm speculating, is that the governor got frustrated in the first couple of weeks, that the hospitals that he initially put in charge of this, remember at first he wasn't going to use the counties, even though the counties had a well-established system of vaccinations. And to his credit, County Executive McCoy raised this a number of times in the press, that they had been overlooked, and all the authority initially was going to hospital hubs. In this region, it was going to be Albany Med. So he initially gave it to hospitals and then became very frustrated that there was a slow rollout. By the way, Albany Med was not one of the slow, well, I know St. Peter's was not one of the slow ones. They were at the, even on the governor's charts, they were at 100% each time for getting vaccines and not providing, getting vaccines and getting the vaccines in arms, shots in arms. So that's one, that's one huge part of this. So, and I mentioned the healthcare workers because, that's been a big issue, but you also read the front page of the Times-Union on Friday on the developmentally disabled. So they too were scheduled clinics, tried to vaccinate the developmentally disabled, obviously by definition, a very, very vulnerable population. They thought they had hit a home run by getting in this 1A category, this top category, a few weeks before. they had, I think it was 1,100 or hundreds. There's 1,100 in the eligible pool there in this region, and they had hundreds signed up to get shots last week. They had to cancel all those appointments because they did not get the vaccines. So, so if you didn't see that article, it's Brendan Lyons in the Times Union who wrote that the other day, and I've been exchanging some information with him to just try to let him know what's going on with the hospitals as well. Again, I'm trying to, I think, you know, the pressure is get shots in arms, right? We don't want shots sitting in these freezers/coolers. We want people vaccinated. The governor, to his credit, wants to make sure he is targeting some very vulnerable populations. As you know, there's been a big push now to get it into communities of color. So there's been some success there. There's been a number of clinics just over the last weekend, just over this past weekend, to try to get those shots out there. So there are good things happening. The shots are getting in arms, but I don't think it's in nearly, when you have a pool of 7 million people who are now eligible, it's not going to be targeted. And again, I say that as somebody who's not trying to pick on 65-year-olds. So I hope that starts to answer some of your questions, and I'm sure I didn't cover all of them. So.
Thank you. Ira, before I turn to you, because I am also cognizant of the fact that we only have Assemblywoman Fahy until 10 o'clock. So Ira, before I ask you to weigh in on that, I'm going to ask one other question of the Assemblywoman, and then she's going to wish that she answered the previous question longer, because this one's even harder. So there was an interesting piece in the New York Times Magazine a few weeks ago, in which there was a discussion of our exact topic of how do you weigh and measure who gets priority in distribution. The one thing that all the panelists agreed on in this piece was that the 1A category of health workers was really a gimme. After that, they said it gets complicated. And they were really quite forthright about the fact that, you know, once you get to phase 1B, which was originally people over 75, 20 million. You know, frontline essential workers, you know, depending on the category, how you define them, but there's another 30 million people nationwide. And that's just based on the federal guidelines, which states do or don't have to follow. But the panelists that sort of went in to discuss the fact that the average age of death from COVID for a white person is 81, for a Black person 72, and for a Latinx person 67, which means that for some of them, using the cutoff of 75 was not really all that beneficial. You know, they talk, and we've all seen how issues of race and ethnicity have been exacerbated in how this has impacted on certain communities, including the ones I mentioned, and the Native American populations, who are being affected significantly higher rates. And they also introduced some of the challenges that we've seen in other areas, such as education, between urban and rural distribution. So even if you manage to get into one of the higher categories and you're wonderfully eligible, but if you live sort of just to the west of the middle of nowhere, it may not matter that you're in this nice category. And that's, you know, and we saw how that was true in terms of internet service for schools and a whole host of other things. So the simple question is, how can we, recognizing the huge diversity of New York State, but with all the various subpopulations that are impacted and the geographic dispersion, how do we do a more equitable distribution, recognizing that using major hospital hubs is easy or easier?
Yeah, I was just going to say, not easy, but right. Easy, you know, well, how do we do this? So it's hard to put put any of this back in the bag, right? We've now announced that 65-year-olds and older are eligible. And as we said, overnight, that dramatically expanded the pool. You were giving some national statistics. The ones I had used before, the 7 million is just New York State. So we have only 19 million people. I'm waving at Gary's adorable child. Sorry. So overnight, 7 million of our 19 million people, again, that's 19 million includes our children. So how do we put this back in the bag? I'm not sure, but I think we have to go back at reprioritizing. We can't call our healthcare workers, our frontline hospital workers, heroes on one day, and then put them essentially at the back of the line or give them 0 vaccines the next day. That doesn't mean we give them just exclusively to hospitals. Yes, we need to continue, but to give them 0. A week ago, over 5,000 vaccines were given to UAlbany. I don't know how many are being given this coming week, and 0 were given to St. Peter's. So there is this, in my view, a fundamental unfairness. And by the way, it is hard to make this somewhat equitable. You mentioned the rural, all these underserved or underrepresented populations. As you mentioned, people of color who have had the most impact. Some of the highest death rates. They're not necessarily hospital workers. So yeah, they weren't by definition in the 1A category. So I know that was met with some backlash. The rural versus urban area, the physical access, although we've all read the stories of people getting their appointments up in Plattsburgh and going to Plattsburgh. So in some ways, some would tell you Plattsburgh's doing a little better than the capital region right now in terms of accessibility to the shots. But personally, what I think we need to do is, I was talking to a sibling in Illinois, and I didn't go into a detailed conversation, but she is registered. So she's been able to register because she's 65, but she hasn't been given a date. So I think we need to rethink how we are, I know we've been crashing systems, but first of all, it's one thing to get people registered, but does that automatically mean they should go to the front of the line? I think we have to go back at this, let people registered because we've already told them they could, but maybe they don't get the immediate date until we can get through these hospital workers, or other healthcare frontline workers. One of my doctor's offices reached out to me right after the announcement came out and said, wait a second, what about healthcare workers in doctor's offices? And they ultimately were added back in. But I think we need to redo the priority, go back at this fairness issue and let people register, but those who are in the priority list would get the earlier dates. And of course, that's much easier said than done, but you can't tell the developmentally disabled, sign up, register. I mean, the emotional whiplash that must have been on the developmentally disabled community had to have been horrific, to think that they've signed up, their families were ready to go, get their loved ones vaccinated, only to be told that it was canceled. So it, again, not easy to put any of this back in the bag, but I think we have to go back at this prioritizing and keep the registrations, but better target the shots, or at least give some shots to these hospital workers and not give them 0. And again, I'm only speculating when I say, were they being penalized for not moving fast enough? I really, it's a legitimate question because I don't know why they've been given 0. St. Peter's is entering this week, their 3rd week of receiving 0 vaccinations. And we know they haven't hit 100%. And by the way, I mentioned the workers. I should have, of course, added in the patients. By definition, you are probably a lot more vulnerable than an average 65-year-old if you're already a patient in a hospital. Again, depending on what you are there for. But the fact that they're just left hanging is, to me, this just strikes as a fundamental unfairness. But again, I know there are the politics of this. But my issue is, how can you call somebody a hero one day and then ignore them the next? So I'm still trying to raise these questions, talking to a host of colleagues. I've been in regular touch with 8 of my upstate colleagues as we try to assess this, and it's rolling out differently in different areas of the state. But you saw even in New York City, they had thousands of vaccine appointments that they had to cancel late last week as well. So to say it is chaotic and to say this is a bit of a mess, I don't think I'm being unfair. I hope that answers some of your questions, David. It's I don't have all the answers. I was looking, I wanted to pull up the eligibility list, but I'm just going to read to you because I need to refresh my memory on who is in 1A. And they've now merged 1A and 1B. So 1A and 1B, they're listed on the governor's website. They're listed together, but it is the developmentally disabled, like OPWDD, urgent care providers, outpatient, ambulatory, frontline, high risk healthcare workers, any staff who are in direct contact with patients, all frontline healthcare workers. The list is EMS workers. The list goes on and on and on. We're not making a dent in it because now the pool has been so broadly opened. And again, I don't think it's fair. And but again, easy for me to say. I know there's a lot more 65 to 75-year-olds who say they want their turn and, and have many other reasons. They have many. Politically, it's a difficult issue.
Thank you. Challenging questions for all of us to continue to ponder. I'm going to thank Assemblywoman Fahy now, because I know that she has only a moment or two before she has to.
Yeah, David, I was. Let me just add, I was a good 5 minutes late. Please, I've got. I'm more than happy to take another question or answer any. I've talked a lot, but I want to hear more. I really am. I'm not going to do a press event tomorrow because I'm still trying to drill down and get some better information. We're trying to get I've asked St. Peter's for the percentage of their workers who have been vaccinated, let alone their patients. I'm asking the same of Albany Med. So I am trying to get better information, as you know, that's been a fluid situation, trying to. This is all happening in real time, right? So trying to track these issues and trying to get better information from a number of my colleagues. It's worse in some parts of upstate than it is in others. But please go ahead if there's another question. I was late, and my apologies.
No, that's okay. I'm actually going to let you catch your breath for a minute, and I'm going to ask Dr. Zaikon to sort of weigh in on some of this conversation, but bring his medical lens and perspective to bear.
Okay, thank you, Rabbi. There's many layers to the question. So, I think one, as a healthcare worker and directly serving the hospitals as well, there is not controversy in terms of the prioritization of that initial tier, right? We understand it's not just a matter of being in the trenches, it's maintaining the sustainability of our healthcare delivery, right, at the hospital level in a crisis where there's already limited resources. So that's the imperative. The supply chain part of things obviously is a critical limiting factor. If the supply doesn't meet the demand, then there's going to be, how do you prioritize the delivery of limited resources, waiting for that supply to begin to match the demand over time. So I agree with the Assemblywoman, as I was thinking through, just from a logistical standpoint, is you do want to maintain the prioritization and yet be able to have a list of citizens in queue, and yet be able to flip to the priorities, and then if there's slots, go to the others, and yet be able to keep track of that. So that's it's beyond me as to know what the scheduling solutions are from a technological support and human resource support in terms of being able to do that. That's obviously to understand. This is a complex circumstance. And I think the other aspect that, representing, let's say, physician practices, that's been the other element, getting healthcare workers in the outpatient settings, vaccines as well. They're patient-faced. And again, they're part of the important delivery system, because one of the other things that we saw in the first experience of COVID, when people weren't going to the emergency rooms, they weren't going to the hospitals, they weren't going to the urgent cares, they were reporting this was the downstream effects on other health, delayed care, delayed attention to care. And of course, if that doesn't go well, there's not only poor outcomes, but there could be increased stresses on our hospital when the volumes of the bed needs might go up. So we still have to look holistically. And so, I know we can reflect at the personal level, let's say our oncology practice, had submitted applications to get vaccines, at least to prioritize getting our healthcare workers. And we were more asked, well, could you deliver at a larger scale to the general population? So it wasn't going to be just for our healthcare workers. Well, we then rapidly looked at, okay, can we scale up? How do we do that? What's the human resources we need? How would we deliver it? Preparing to do so, but still have not been able to obtain any vaccines, even for our healthcare workers. So I presume that reflects generally across the outpatient spectrum of healthcare practices.
Yeah, community care has had the same experience. We were definitely ramped up to give, and it was in the paper this morning, the article.
Yes. Yeah, how could I forget? I think it's 56,000 patients that they serve, and got zero again last week when they were expecting it. Zero. So thank you for mentioning that, because that's another big one. Sorry if I'm sounding incredibly frustrated. It's just, there just is a fairness issue here. And I was looking for an email because I wanted to give you an update from, I can't, hold on just one second. It's from the Alliance for Better Health, Jacob Reeder, if anybody knows him. That's an alliance that works with a whole host of healthcare providers. And he too has said, like, they're actually willing to help with some of the technology here, because as you know, the technology alone has been maddening for people. But he also talked about a pre-registration, so maybe there is something you can do. If you meet certain categories, you get a certain date. If you don't meet certain categories, you don't. And I should add, I've mentioned the healthcare workers and patients and how unfair some of that is, the ones in 1A in particular. But then you've got 1B, teachers and professors were added in 1B. I've often said, because I just would be remiss if I didn't mention this, I've often said, COVID has caused an economic upheaval, right? And by all accounts, it's going to take us a few years for the economy to recover, right? But the economic devastation of COVID, in my view, is nothing compared to the educational devastation, especially of young students, especially of students who do not have a lot of support at home. They have in many ways lost a year, because virtual learning, by and large, is not good, not helpful, not even anywhere near as successful as in classroom learning for most children. Some it has benefits, but you need tremendous support. So not putting teachers, for me, it's the healthcare workers, the patients, And by the way, I define healthcare workers very broadly as, and I listed some of those. But then you've also got to get teachers. We've got to get these schools back open. I live here in Albany. My children went to the Albany schools. We have 70% poverty. For many years, it was labeled as, most of our schools here were labeled as failing schools. And they've been 100% virtual since last March at the middle school and high school level. It's an educational travesty. It's an absolute travesty. And so again, but how politically, I understand, we've now said 65-year-olds. And so teachers, the only teachers getting vaccinated are those who knew how to get to the front of the line. So there's been real consequences for this. I would like to see us redo the website and somehow change this up. And so I am part of that pressure behind the scenes and trying to get this out on social media as much as possible, and trying to work with my hospitals as much as possible to, I'm focused on that right now, but then the next big tier I think really has to be teachers, especially those who may have health risks, because we've got to get the schools back open too. So I hope that helps. And by the way, I'm sorry, I should have said Rabbi David. I didn't mean to be. I didn't mean to.
I answered to that before I answered to the other.
No, that's.
So let me throw a question on the table, which I know that this is one of those places where Judaism and the secular world are going to answer differently. One of the things that we've seen is a significant portion of the population who are refusing to get vaccinated. And it's not just in any segment of the community. We see it amongst hospital workers. A colleague of mine was telling me of the hospital in his community, and there was something like 30% of hospital workers, broadly defined, could be physicians all the way through administrators, through people who were, staff that provided support services, but 30% were refusing to be vaccinated, which raises, and then you get to the broader general population. We mandate for admission to the public schools that children, unless they really have a provable medical reason not to, we require MMR. We require other vaccinations, and we track the students to make sure they're up to date so that they can legitimately be allowed into the schools. So can't we do this? Should we do this? Is the public health issue not exactly the same within the microcosm of the school and the macrocosm of hospitals and the country?
Again, great questions. As you can imagine, some of this was so predictable, right? Because we just less than 2 years ago, we went through quite an upheaval, some of our most contentious debates, and one of our uglier votes, if you will, because we, after the measles outbreak, where the World Health Organization said we were on the verge of a mass outbreak of measles, we very much tightened up we eliminated a religious exemption on vaccines. Still a major upheaval over that with those who are opposed to vaccines. So, and I have said, the first phase of the COVID vaccine is going to be who gets it, right? Which we're in right now, and we've just spent the last half hour talking about. So right now we've got this scramble of who's getting it, but the very next phase, as soon as we get more vaccines, and again, so much of this is caused because we just don't have the availability yet from the federal government. I truly hope that's going to change in the next few weeks. I'm confident it will. But then the next phase is those who will or who want to hold off or refuse, including already the studies are showing, some estimates are 30% of hospital workers. So we are going to have to tackle that, what that's going to mean. And then I have a colleague who's already introduced a bill about the schools, a study to evaluate whether it should be mandatory for schools. I personally, I'm not a co-sponsor of that because I want to get through this. I don't want to get into the, vaccine, mandatory, not mandatory, until we can get over this hurdle, because I want our focus on getting the vaccines to those who want them and prioritizing better. But we will have to tackle that. I think at this point, there is and we've heard this over and over, we need at least 70% to begin some herd immunity. So soon enough, we will have to tackle that. But I'd rather not scare people right now. I'd rather keep the focus on let's get the vaccine out and let's continue then with the public health promotion that this is about making your community safer. I'm pretty healthy, thank God. I have not rushed to be at the front of the line of the vaccine. I have a son who has serious health, has had a horrific year with some serious health crises. So by definition, I'd love to be at the front of the line, but I don't, for all the obvious reasons. But anyway, where was I going with that? Normally, I wouldn't be as worried about myself or whatever, but I see it from the other lens. In order to protect my son, I want the population to be, so it's not about me or, whether I have hesitancies on vaccines or you, it is about protecting the rest of the population. And so I think we are going to have to continue to convince people, one, that it's safe. And I think, there's been yeoman's work done to convince people that this is safe. But then two, to convince people it's not about the individual here. This really is about protecting the rest of your family, your neighbors, your community. And that's going to take a little bit more time. So we need to get through these next 2 months or next, good few weeks, whatever it's going to take to get to those who actually want the vaccine. And then we are going to have to look at what is it going to take to using our healthcare providers, using public information systems to really convince people this is not about you. I don't, as I said, I don't go to sleep at night worrying about myself, whether I'm vaccinated or not. It's just not, I have enough other worries. So I recognize if I get a vaccine, it's not about me. It's about protecting my son, my family, my community, those who I encounter in my job. I want the Capitol back open. This is not a way for us to do business, is doing it by Zoom. I'm spending, I think we have to convince the rest of the public that this, we have to put our community before self. And again, recognizing those who, as you said, Rabbi, there are some people who need to hold off because of certain serious health compromises. Those are medical questions I recognize may need to be answered separately, but that's a very, very small fraction. So I hope that answers. And if there's any, I have to shift gears now. And since then I did get another text from St. Peter's, and we're trying to get on this, and I really hope we can make a dent in some of this in the next week. But
I have a question for the congressperson. The prevention element is very critical too, because with the current situation of the virus taking place, there's a confounding variable of suicides and homicides. Nevada, for example, today reported tons of suicides by kids never being able to go back to school. Homicides are very commonly increasing in the low-income neighborhoods. So the sooner we get the vaccine, the sooner we will be able to resolve the overlying new effects of the conditions that we're surrounded by. I'm speaking as a public health official.
Yeah, thank you for saying that, and thank you for the promotion. But I'm actually your Assemblywoman. I'm not your Congresswoman, but I do appreciate the thought. But I'm so glad you mentioned that, because another issue, and this is something I also say regularly. I mentioned healthcare workers and patients and educators and schools. But one of the statistics I think is the single most underreported statistic in the last 10 months here is the mental health crisis that we are facing. And I don't know a family, especially a family of school-age children, that is not going through some type of a crisis, whether it's school age, college age, or what have you. Let alone those who are so isolated. I just think it's one of the most underreported issues. I personally, and I think the data is showing this, but again, so much of the data is very early, but I think the violence, we know we've seen upticks in domestic violence. We know we've seen huge upticks in suicide, but that data it lags, as you know. So it's going to be hard to track, but again, I think this is, in my view, it's one of the most underreported, because I think the mental health consequences of so much of this, just the emotional trauma, right? I mean, think of these elderly. I've heard story after story of people crying when they've gotten their vaccine. The 96-year-olds who have been so isolated from their families. And so the emotional trauma alone, and anyway, but the suicides, the domestic violence, the street violence, you name it, I think there's a direct correlation. So thank you so much for bringing that up. And with that, I think I'm going to stop there, because I know you have another agenda, Rabbi, unless there's anything else. I love the.
I don't know if you've been following I don't know if you've been following in the chats, but I'm going to add my thanks to the chorus that went through the chats. Thank you for joining us this morning and for sharing all your thoughts and insights on what is going to be a roiling and difficult subject for many, many months to come.
Agreed. And please stay in touch, and please email me. If you just Google my name, it has the email. It's a simple one, or call. I should have added in the chat room. I'm sorry. But my office number is 455-4178. It's the 518 area code, 455-4178. My email is fahyp@nyassembly.gov. fahyp for Pat @nyassembly.gov. So I welcome, I welcome your input. And by the way, I hope that people will continue to speak out. Dr. Zaikon, I got that wrong. I really hope, sorry, thank you, Zaikon. I really hope people will continue to speak out about the fairness issue here. And that's all we're trying to, but I may have a different definition of fairness than others, but we are just trying to prioritize. So thank you again. Thank you for having me. Happy to come back anytime. These are really tough issues and challenging us to our core, I will say. And none of this is going to be solved overnight, but I think we do need to solve them. We still need to solve them as expeditiously as possible. So thank you again. Such a pleasure, and nice to see so many, and Gary, so nice to see the family. All right, thank you. Bye now. Bye.
Thank you.
Thank you for joining us.
Yes, much appreciated. Bye now.
Ira, do you want to weigh in on this a little bit, and then I'm going to take a turn before our time runs out.
Yeah. I mean, certainly appropriate that she had the time, given to her, because you're really talking about much larger issues of distribution, really, which is really well above a practicing physician. But a couple of comments, I guess. One is clearly, again, the supply has to increase, and it has to be allocated to meet needs across a very diverse nation. So that's obviously challenging. The issue of wasted vaccines, of course, drives anyone, crazy. It's the most illogical and tragic circumstance, and it has to do with how this is constructed. That's where having a flexible list, but with some control, so it's not creating chaos, makes sense. Or whether instead of moving people, you move inventory. You know, can you have the ability to shift vaccines that are not going to be used into another location where they will be used, as long as there's a system of allocating it to people in an organized way. You know, we do that at our level of practice because we have to handle a lot of drugs in inventory, and you have to make sure your supply chain is there, and you have to decide how you're going to get things where they need to go. You know, it's very hard to comment at a systems level. I think that I think we are underutilizing practices that have on their smaller scale, even if they're large for a practice, the ability to organize perhaps in ways that are more difficult at a macro scale, and have the patient contacts that they have, certainly from a primary care standpoint, as well as some specialty practices, and could really help deliver. But that's not been part of the solution. I think, you know, that this is certainly the aspect of not wasting vaccine and just getting people, as your example, Rabbi, you know, come in, although I don't know how you ended up being called. What, you know, that probably raises the question of who has access, who doesn't, in a timely fashion. But the imperative is still to get the majority of the population vaccinated. That's that herd immunity. So going into anyone is of ultimate benefit in the long term. And the more rapidly you can get your population vaccinated to get to that 70%, 80% threshold, you know, ultimately then achieves the communal purpose. That's what we actually have to get to, even as we're prioritizing particular sectors. And I think this is, you know, the pandemic is certainly exposing discrepancies, you know, that exist for a variety of reasons, of access to transportation, if you need transportation, family support, do they exist, do they not exist, communal support, does this not exist? And of course that dovetails into mental health as well. So it really has exposed so much, right, in our society where things aren't working, and you have to then solve for that. So again, it makes sense if there's communities that don't have access, that you set up shop there, you know, tents with the ability to deliver, whether that's rural or city. But I'm talking more from a logistical standpoint. I'm not at the policy level, not at that macro level, but those are thoughts that, you know, that I would have in terms of ultimately trying to be fair in the distribution, as well as getting as broad as possible, which is where we have to get to.
Thank you. I'm gonna sort of finish the answer. So part of what we're seeing now is this scramble, and I was part of the scramble. It's really, you know, had Jody not picked up her phone at that moment, she wouldn't have gotten the message. She would have gone on Monday, and I would have sat and waited patiently till my turn came up many, many months down the road. The fact that I got called is really secondary, because the call really went initially to people who are in the category of 1B. And I just got schlepped along because I was there. And someone thought to mention that I should tag along, because it didn't occur to me automatically, or to Jody automatically, because it's like, okay, this is not my category. On the other hand, if the category becomes use it or it goes to waste, or use it on you as opposed to some other random human being, then I'm as good a random human being as any other. And that was sort of part of the thrust of the article that appeared in Thursday, in that op-ed piece in the New York Times on Thursday, that was entitled "Take a Vaccine If You Can." Right. And it was interesting in reading the article. One of the arguments that she makes sort of came straight out of the Gemara. And I'm going like, well, you know, even if you're not quoting it directly, it's good that you know your sources, because part of the Gemara's argument is that you can't always know whether the person A's life is more valuable than person B's. And in this case, when they're randomly trying to fill slots, it's like, don't say someone else should go first because they're not as healthy as I am, blah, 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 blah. Because dafka in that randomized moment, that may or may not be true.
Yeah, but it's again true from the larger perspective of trying to get herd immunity. You know,
right, and that was her second point, is that eventually you're going to need to get one, and if you have the opportunity, you should do it. So I have to say, lots of these thoughts were roiling around in my brain as Jody's bouncing us along, you know, the road to get to the hospital, to the Times Union Center. So it was an intriguing argument that became very much not theoretical as we're driving to the place. The other thought that I wanted to pick up on was Assemblywoman Fahy mentioned that during the discussions regarding vaccinations for school, that the religious exemption was removed. I have to say that as a rabbi, that Jews were claiming a religious exemption was so deeply offensive that I may have, you know, really miffed off a couple of people because I told them exactly what I thought of that. And I used some language that was kind of colorful because it is just not true. You know, it is not true in any part of the Jewish community. You know, you have, you know, ultra-Orthodox rabbis like Yosef Eliashiv, who essentially talks about students who are not vaccinated and are being sent to school. He calls them mazikim. A mazik is someone who's harmful, someone who injures, someone who causes damage. Right? That's his language. That's not the language you usually use about children, right? But he was trying to make the point of that's the degree to which our tradition requires you, as a reflection of communal good, to do whatever you can to ensure your health and the health of the community. And he's not like a one-off voice. You know, this is like a chorus. It's a very large chorus of rabbinic authorities that say that this is a requirement. This is how we fulfill a divine mandate. Though, and it was intriguing to me to look at how different movements have spoken about this, and almost universally, it's been, this is a mitzvah. This is a moral, ethical, Jewish legal obligation. It's not voluntary. It's not a matter of choice. It is, from a Jewish perspective, mandated.
Well, I can't speak to. I mean, I suspect it's, in a sense, using a loophole, right? You come from a different reason that you don't want the vaccine, and you're using this as your vehicle to get an exemption if it was on religious grounds. You know, I think that there's different reasons that a significant proportion of the population chooses not to get vaccinated, and it's different depending on individuals or communities. I think we're, unfortunately, you know, we can see we're at a time of a level of mistrust of public institutions, of government, of politicians, and even of science, in a context of a rapid development of a vaccine. But you have those that refuse simply because philosophically they're all about individual autonomy and the community is not the priority. You have those that mistrust the vaccine because of past experiences in the Black community, for example, of experimentation, you know, back in the 50s with syphilis. And that is part of the conversation because it's shared with me by some patients. You know, that's some of the conversation in the community. So a lack of trust on getting the vaccine. I can't explain healthcare workers. It's boggling. It's saying there's something very disturbing going on if up to 30% of healthcare workers in a science-based, field are choosing not to get vaccinated. So that's a challenging question, and I think there's diverse reasons that's going on, but obviously it it creates access for others, which is what's happened, but never to waste a vaccine. But that was leading, I think, to some wasted vaccine. I mean, the other part that is mentioned is kind of I think a lack of coordinated thoughtfulness about how policies are rolled out, and it's not coordinated with delivery systems. It's not coordinated with how this would all play out. What the CDC says doesn't mean that's going to translate easily on the ground. If you don't have either the supply chain or the organization to deliver that, you're going to create chaos. So that's been a pattern throughout, although we can understand that there was a big learning curve in the first, I'd say, 6 to 9 months of this pandemic of what is this doing and how to adjust to it. And things were changing constantly, but it was somewhat understandable. I personally don't understand how we're at where we're at, because there's been plenty of time to figure out how are you going to deliver this as long as the supply is there.
Okay, Ira, thank you. I'm going to thank Ira, not just for the immediate answer, but for taking the time to offer his insights and his expertise over the last 2 Sunday mornings. In absentia, I thank our political persons who joined us, Assemblywoman Fahy this week and Senator Breslin last week. They brought their own important voices to our conversation. And I want to thank all of you for joining us and participating. And to sort of end on a sort of a lighter note, I share with you the following quip that someone shared with me earlier this week, which is that if we could train Amazon drivers to deliver the vaccine and administer it, we could cut the time in half. So
That's a great idea.
That has to do with supply chains, though. You're really talking about supply chains, and that's part of the issue. How do you?
Ultimately, you can't administer what you don't have. But it brought a smile to my face when I heard it, so I share it as a way of ending on a smiling note.
Ira, can you possibly end on an optimistic note regarding the one-shot vaccine that's supposed to be coming out, and hopefully increased rollout of production with the new administration? I mean, it's still, New York State system still has to work, but I kind of don't want to get off. I don't want to get off totally depressed.
Right. Well, I think that when you look at the vaccines, so obviously the first vaccine that was approved, the Pfizer vaccine, required the ultra hot, cold temperature storage. So that's a limiting factor because you have to be able to have that refrigeration technology available. So that's going to limit the sites that can do that. Perfectly legitimate as long as you can match it up to a delivery of prioritize people to get that vaccine. And hospitals were capable of doing that. And some practices would be capable of doing that. The Moderna vaccine, not quite the same stringency of requirements, and yet has a limited shelf life in the refrigerator. But that expands a little bit more flexibility. The Johnson & Johnson vaccine, not yet approved. I think, again, as long as the efficacy is comparable, which I think the reports look like they are. I think it's also in that 90% range. Then one, it increases the supply chain of any vaccine, right? So as long as you can continue to scale up your manufacturing and distribution, then you're going to start meeting the population volume demands. And then if the stringency of how it's administered is easier because it's 1 shot versus 2 shot, and I don't know about its shelf life in terms of how it has to be handled. Again, that's going to expand the ability to deliver vaccine. So all of those components would be positive, right? Increasing the supply chain, getting it delivered, and making it more feasible to deliver it despite the complexity of doing that. At the same time, as the Assemblywoman spoke, you always need to recalibrate. You got to say what's not working, what's working, and what are the solutions, and how do we operationalize that in rapid fashion. That's where I think you should look to sectors that can function more flexibly. Sometimes a big healthcare system is not so easy. And there's others on the ground, whether at the county level or at practice levels, might be able to flex more rapidly to deliver. And I think that's untapped resources.
Absolutely.
Thank you, Ira. Thank you, everyone. Have a very wonderful day, everybody.
Thank you. Great program.
Really
Thank you.
great program.
Thank you, everybody.
Thank you.
Thank you, Rabbi and Ira.
Hey.
Yeah.
Thank
Great
you.
information.
Stay
Thank
well.
you.
Both.
Stay warm.
Stay warm, everyone.
Gotta find my Bernie mittens.
All right. Heading out to cross-country ski.
Well, enjoy.
Enjoy.
Use us.
Bye.
Bye-bye.